Hello, good morning, friends. And today we'll be discussing about hydrocephalus. Before going into the details, I would like to thank Chandana Shri Ma'am for sharing the wonderful notes with us. And today we'll be discussing about hydrocephalus. It will be helpful for MS, DNB, and SS exams. Also, it will be useful for MBBS exams, surgery. So, what is hydrocephalus? It is characterized by accumulation of excessive CSF in the cranial cavity with resulting dilatation of the cerebral ventricles, raised ICP, and enlarged cranium, especially in the infants when the skull is not fused, and over time resulting in brain atrophy. Now we'll see the physiology of CSF, how the CSF flows. So CSF is produced by the choroid plexus which line the ventricles. So these are two lateral ventricles which is connected to the third ventricle through the interventricular foramen of Monro. Then surrounding the third ventricle is the thalamus, and from the third ventricle up to the fourth ventricle through the cerebral aqueduct of Sylvius. Then from the fourth ventricle to the subarachnoid space via the foramenas various, which is foramen of Mbbs.Ms.Dnb, which is in the midline, and foramen of Luschka, which is on the both side laterally. From there it will be connected to the subarachnoid space, and below it will be connected to the spinal cord canal through the central canal. And in the subarachnoid space, it will be reabsorbed by the arachnoid villi, which will reabsorb the CSF. And now, what is the total volume of CSF? It is 150 ml, and it is produced at the rate of 20 ml per hour. It is absorbed within 8 hours. So बन रहा है 150 ml, प्रोड्यूस हो रहा है at rate of 20 ml per hour and absorb हो रहा है within 8 hours. So accumulation of CSF in hydrocephalus, intracerebral or extracerebral, within the ventricles in the intracerebral and within the arachnoid space and cisterns in the extracerebral. So it could occur in the intracerebral and extracerebral space. Now we'll go for the causes of the hydrocephalus. So first is increased production, यानी बन ज़्यादा रहा है. It could be due to choroid plexus papilloma, tumor in the choroid plexus, or it could be due to obstruction of flow of CSF, or it could be due to decreased absorption. So obstruction of the flow to CSF, it could be divided into two, that is non-communicating hydrocephalus or communicating hydrocephalus. Also in the type where there is decreased CSF absorption, even in that there is communicating hydrocephalus. So now we'll see in detail about the non-communicating and communicating hydrocephalus. So non-communicating hydrocephalus, when the communication is lost between the ventricular system and the subarachnoid space, there is no communication. It could be due to obstruction at or proximal to the foramen of Luschka or Mbbs.Ms.Dnb, like obstruction in the ventricular system. The examples would be aqueductal stenosis or gliosis, interventricular hemorrhage or tumors. Then we have the communicating hydrocephalus, where there is communication is established and there is no blockage between the ventricles and the subarachnoid space. There's obstruction is distal to the level of foramen of Luschka or Mbbs.Ms.Dnb. This is commonly seen in infection like meningitis or brain infections, subarachnoid hemorrhage, leptomeningeal carcinomatosis. Then it could also be differentiated on the basis of injection of a dye into the ventricle and then doing lumbar puncture. If the dye appears in the CSF, then it is communicating type of hydrocephalus. If dye does not appear in the CSF, then it is non-communicating type. And these classification of obstructing, non-obstructing is based on the ventriculogram and pneumocephalogram findings. Then based on the duration, it could be acute, like in days to weeks, like due to tumor or meningitis. Chronic hydrocephalus, where it is month to years in case of normal pressure hydrocephalus. Types based on presentation, it could be congenital, it could be acquired. Congenital at birth, Most common cause is the obstructive, and non-obstructive could be due to toxoplasma or CMV infection. Acquired could be due to trauma, tumor, or normal pressure hydrocephalus. Now we'll see some special types of hydrocephalus. That is hydrocephalus ex vacuo, where the ventricles enlarge as a compensatory response to overall shrinking of the brain tissue due to the old age senile cerebral atrophy or neurodegenerative disorders. Then we have a benign external hydrocephalus, which is due to relative immaturity of arachnoid villi, and it is due to decreased absorption of CSF in these villi, especially seen in children with macrocrania and mild developmental delay. It is usually self-limiting. Shunting is needed if it does not resolve spontaneously by 2 years of age. Then we have normal pressure hydrocephalus, which is a type of communicating hydrocephalus. It is due to the increased resistance to CSF flow, and it is due to decreased absorption of the arachnoid granulation. So ICP is normal due to compensation mechanism. However, there is transient elevation, मतलब बीच बीच में बढ़ता रहेगा ICP, leading to ventricle size increase and new fluid equilibrium, intracerebral fluid. It will be establishing a new equilibrium. There will be no identified cause, but meningitis, trauma, or SH may also contribute to this. There is a classical triad which is seen in this normal pressure hydrocephalus, that is gait ataxia, cognitive impairment, and urinary incontinence. So पेशेंट का गेट गड़बड़ हो जाएगा, अटैक्सिया होगा, ठीक से चल नहीं पाएगा, समझ नहीं पाएगा, कॉग्निटिव इम्पेयरमेंट है, देन यूरिनरी इंकॉन्टिनेंस, पेशाब रोक नहीं पाएगा. It is generally insidious onset, commonly seen 40 years of age group, यानी elderly में मिल रहा है. Minimum duration will be more than 3 to 6 months and it will be progressive. Then we have porencephaly, where there is focal loss of volume in the area of brain. It could be due to stroke or surgery, resulting in localized collection of CSF in the cavity. Then there is a arrested hydrocephalus, where there is ventriculomegaly without any feature that warrant intervention. Symptoms may develop eventually or after some precipitating event like trauma or infection. So now we'll have the clinical features of the hydrocephalus. So what are the clinical features? First, we'll see in the infants when the cranium is not fused. So there will be increased head circumference. There could be fullness in the anterior fontanelle with or without some bulge. Prominent dilated scalp veins. Scalp veins will be dilated. Sunset due to sunset sign due to compression of the third ventricle. Then there will be downward deviation of the eyeballs. This is especially the sunset sign and is seen in Perinaud syndrome also. There will be irritability, refusal to feed, vomiting, lethargy, drowsiness or coma. Then we have the older children or adults where there is no cranial enlargement as the fontanelles are fused, raised ICP and brain compression. It could be rapidly progressive, resulting in new onset headache, सर दर्द होगा, उल्टी होगा, visual disturbance in the form of papilledema, optic atrophy, सीजर्स हो सकते हैं, हर्निएशन हो सकते हैं, और जो सर्वाइव करता है उनको हेमिएनोपिया हो सकता है, विजुअल फील्ड डिफेक्ट हो जाएगा. Then chronic, where there will be slow accumulation, there will be progressive dullness or apathy in the patient, memory will be affected, gait will be affected, and urinary incontinence. So this normal pressure hydrocephalus is similar to this one, chronic hydrocephalus. So now we'll go for evaluation of hydrocephalus. Apart from the history and examination, the CT and MRI, it will tell us, especially in the communicating hydrocephalus, there will be overall enlargement of the ventricle, and it will be symmetric. Whereas in the case of obstructive or non-communicating hydrocephalus, it will be asymmetrical dilatation of the ventricles. Then the cranial USG in the newborn or infants with open fontanelle. Cranial USG will show us that there will be increased size of the ventricle, dilated ventricle. CT will also show us the dilated ventricle, and degree of ventriculomegaly may show tumor, shunt, or cerebral parenchymal atrophy. MRI is the investigation of choice. It will help us in detection of the site of obstruction, small tumor or cyst. Also, it is very important investigation before endoscopic third ventriculostomy or aqueductoplasty. Plain X-ray will help us show the sutural separation, erosion of the posterior clinoids, and beaten silver skull due to increased convolutional markings. SPECT acetazolamide challenge will also be useful. Now we'll see the management of hydrocephalus. So most importantly, it is important to reverse or decrease the damage due to increased ICP and reconstitute cerebral mantle to allow normal development. And you have to also try to decrease shunt dependency. Should not depend on shunt. Redirect CSF flow if restoration is not possible. So medical management, which is temporary only in combination with surgery, where we use acetylozamide or acetazolamide or furosemide to decrease the CSF secretion. Other temporary measures like lumbar puncture or ventriculostomy until the tumor is resected. Surgery, it could be shunt surgery or non-shunt surgery. So non-shunt surgeries, we have endoscopic third ventriculostomy when there is obstruction at or beyond the aqueduct, as in seen in the aqueductal stenosis, gliosis, or tumors or fourth ventricular obstruction. Here we create the fenestration in the floor of the third ventricle between the mammillary body and the pituitary races, result in obstructed CSF being diverted to the basal cisterns. So it will be helpful for the obstructive hydrocephalus. Then we have endoscopic aqueductoplasty, where we do endoscopic recanalization of the stenosed aqueduct of Sylvius. Then aqueductal stenting, where we will go for endoscopic stenting, and stent is placed and connected to subcutaneous reservoir. Then we'll see the shunt procedures, where we'll be going for ventriculoperitoneal shunt, where the frontal or occipital horn of the lateral ventricle is communicated to the abdominal cavity through a subcutaneous tunnel. Then ventriculoatrial shunt, ventriculopleural shunt, and lumboperitoneal shunt. It is used in communicating hydrocephalus in case of pseudotumor cerebri, where the lumbar subarachnoid space is connected to the peritoneal cavity. In the shunt, we have catheter walls and CSF reservoirs. So now we'll see the shunt complication. It could be over drainage, low pressure headaches, accumulation of fluid or blood resulting in subdural hygroma or hematoma. It could be used with help, it could be decreased with help of systematic monitoring and decreasing the over drainage. Then we have slit ventricle syndrome, which is seen in children. There could be disconnection of the shunt, infection of the shunt, ventriculitis, meningitis, peritonitis, wound infection, etc. Common organisms being Staph aureus, epididymitis, and gram-negative bacteria. Could be blockage of the shunt or distal complication like ascites or pseudoperitoneal cyst. So this was all about hydrocephalus. So hope you have understood some part of it, and keep studying, keep growing. The notes have been given in the description. There's a link you can download from there. So keep studying, keep growing. Thank you for watching. Please like, share, and subscribe. We'll see you in the next video.